HER2 breast cancer has been the great success story. I've been doing this for a while, and I remember when I was in fellowship, if you found out a patient was HER2, that was nothing but bad news. And then trastuzumab came along, and then we've had the small molecules like lapatinib, and we've had the antibody-drug conjugate and pertuzumab. So it's got us to a place where we really want to start thinking about, is this one of those curable malignancies like testicular cancer or Hodgkin's disease? One of the troublesome areas in HER2 breast cancer remains the brain metastases that develop with patients that have advanced disease and go through multiple therapies. Most of our drugs don't get into the brain very well. That just highlights back to the fact that we've got to cure this at the surgical end of the spectrum. So we know, in fact, that patients with HER2 positive breast cancer are going to get therapy. So it isn't a question of if, it's when. And that's the reason I try to get most of my patients, if we find out they're HER2 positive, to take their therapy neoadjuvantly. This is working from the outside in, put the best medicines into the bloodstream and clean up any cells that are in the bloodstream or in the lymph nodes. Let's go ahead and shrink those tumors. We've seen some positive results with better pathological CRs, and we know if we completely eradicate the tumor to the visible eye prior to doing surgery, those patients have a better outcome. So I think this is a great example where we've got well-tolerated therapies in a setting where we know they're needed, and go ahead and do them before the operation and get a better result.